Good evening to all members present today. I am Dr. Pranav, medical advisor at Dr. Reddy's Laboratories. I am basically looking after the oncology portfolio. And thank you for accepting our invite to be part of this knowledge-based session termed HerVictory, where we discuss the evolving science of management of HER2 positive early breast cancer. Just to lay the foundation of this meeting, I would like to state that Dr. Reddy's has been a leader in oncology pharmaceuticals. We believe in our motto that good health can't wait. It reflects our goal and commitment to provide life saving drugs to cancer patients at an affordable cost. Regarding biologics in specific, we started with the world's first biosimilar, that is Reddy, and our portfolio has grown ever since. Hervicta is trastuzumab lyophilized powder approved for treatment of HER2 positive breast cancer. It is available at strengths of 150 milligram and 450 milligram. But we don't see ourselves just as mere manufacturers of medicine. We think beyond the molecule to ensure that no patient is left behind when it comes to management of HER2 positive breast cancer. With that philosophy in mind, we have a number of patient-centric support programs, which Bhanu will take over and introduce to the all members. Bhanu?
Yeah, sure. Thank you so much. Thank you so much. Just before I move to put your camera on. So exactly, sir, very rightly said by only providing medicines, but their first and foremost belief is to care the patient. So there are a lot of patients and initiatives that they run. In overall, if we talk about oncology services, but just to take you through which HerVicta Plus offers is that HerVicta Plus actually follows an overall a gamut of initiatives which are actually inclined starting from the diagnostic and then giving the patient on the treatment of trust program, and followed by when the patient is during their key giving and giving good nutrition counseling support. So it's a very I would say from the start to during the treatment there is a proper care that HerVicta offers. So next slide, please. So if you see about the diagnostic support programs, at the initial level only, there are two diagnostic coupons which are completely offered by the Dr. Reddy's to the needy patients. Like if the doctor wants to write for any of the patient to his patients, Dr. Reddy's is always in support of providing the IHC coupons and HER2 fish coupons. So these both coupons we provide wherever there is a recommendation from our physicians to the needy patients. So this is about the diagnostic coupons. If we move ahead, we have Sparsh program. So I think this is one of the most wonderful program that actually I think have created a big support to the patient care, and actually falls actually it actually defines that how Dr. Reddy's belief is satisfied about that good health can't wait. So it is actually a patient assistant program which provides accessibility of Dr. Reddy's medicine for cancer patients. And this Sparsh program is actually serving from more than a decade. And actually, and one of the most important things here that this program has actually touched more than lakh patients' lives. So that's how this program is so important for, especially in the cancer care. Moving ahead, the next thing is dietalogs. So this is also one of the very unique activity. As I said that this initiative talks about helps in the quality of life improvement during the chemo cycles, and actually it is a nutrition counseling service where it is available every day in a week, 6 days for 12 hours. So it starts from 8 to 8. So that's the kind of service it provides. Apart from that, it is also available in more than 10 languages, and the program actually gives customized eye charts. Then there will be a lot of do's and don'ts, what specific should be provided during the treatment journey. So with all this, I think HerVicta initiatives actually not only support the patient, but also provide ease to the HCP also, that to decide that how a patient can be benefited with all these three initiatives. With all this, I would like to call upon Pranav again to take the session
Thank you.
ahead.
Thank you very much, Bhanu. As you can see that we have a busy agenda ahead of us. So I would like to hand over the stage to Dr. Rahul Sood sir first, and sir will be talking about the evolving concepts in management of early HER2 positive breast cancer. Dr. Rahul sir, over to you. You may start sharing your screen.
Thank you, Dr. Pranay. I'll just share my screen. Right, I'll make it full screen. I hope I'm audible as well as visible.
Yes, sir.
Okay, so thank you once again to the organizers, and thank you for this opportunity for me to speak on something which I really like, that is the early breast cancer, and that too in HER2 breast cancer. The HER2 breast cancer is what we have come to know over a time period, that apart from the hormone positive, that is the estrogen and the progesterone, there is something called as the HER2, which can be targeted to get better results in breast cancer. So today we will be speaking about early breast cancer. So what is early breast cancer? Since we have a mixed crowd, the early breast cancer is something which is less than 5 centimeters, and it may have a node positive or a negative. So it is classified usually as a less than T2 or low, and node 0 or node 1. So with this, I go to the agenda. I'll be discussing the following within the following headings, that is the adjuvant therapy in HER2 positive breast cancer, that is individuals who have already been operated in low risk as well as high risk. What is extended adjuvant therapy? That is for individuals who have already undergone surgery, and thereafter do we need to extend the therapy which is there. And then we come to the new adjuvant therapy, where the individual receives chemotherapy first and then the surgery, and what happens post new adjuvant. So I have another 15 to 17 minutes to go. So let me start with adjuvant therapy in patients with low risk HER2 positive early breast cancer. And when I talk about low risk, what are these low risk individuals? The low risk individuals are individuals who usually have hormone positivity along with the HER2 positivity. There are ladies who are above the age of 35. They have a low grade tumor, maybe grade 1 or grade 2. And usually the disease is not multicentric, that is, there is a single lesion. So any tumor which is less than 5 centimeters with a node positive or without a node should be considered for adjuvant endocrine therapy if they're hormone positive, and chemotherapy and trastuzumab is only indicated in very, very few individuals. But as soon as the tumor size increases, that is, the tumor size becomes more than 1 centimeter, there is no doubt that the individual, along with chemotherapy, should be given trastuzumab and endocrine therapy. If the tumor size is between 0.6 to 1 centimeter, this is a gray area. It is left to the physician with a number of options, but the discussion in the tumor board with the patient is what is the final treatment. So how do we go about it? Now, this is what started it all in early breast cancer, and there was an elevated risk of recurrence, especially in individuals who were HER2 positive. Therefore, an individual with a T1A or a B lesion, that is lesions which were less than 1 centimeter, the disease-free survival as well as the recurrence-free survival was higher in HER2 status. So therefore, this is another subset which required some form of treatment. So this transcribed into the next study, which is the APT trial, where first, along with chemotherapy, trastuzumab for small, less than 3 centimeter lesions, who were node negative in early breast cancer, was introduced. And they found out that there was an improvement in the disease-free survival in the HER2 negative population. So it was a 7-year report which first introduced trastuzumab to early breast cancer, that also which was node negative. This was followed by an attempt study design. This is a recent study. I won't say it was followed by, but this was presented at the San Antonio Breast Congress, where they wanted to compare the new kid on the block. I won't say the new kid anymore, but it is the monoclonal drug antibody drug conjugate, that is the TTM1, versus the trastuzumab paclitaxel combination. The main importance of doing this study was to see whether there was any difference in the side effect profile between the two drugs. So this was done again in early breast cancer. Individuals had to have a good cardiac profile with an ejection fraction more than 50. And what they really found out was that what was the difference in the hematological toxicity, neurotoxicity, and what they found out was TTM fared worse than the trastuzumab paclitaxel combination. So therefore, attempt did not meet its co-primary endpoint of 40% relative reduction in toxicity with TTM1. So does it mean old is gold? Probably from this, definitely, that a combination is better than the drug conjugate when it comes to the toxicity profile, even in 2019. So now adjuvant therapy in high-risk individuals who are HER2 positive, once again, ladies less than 35, high-grade tumor, multicentric tumor, and who are probably hormone negative. So in such individuals, usually the treatment remains the same, that is chemotherapy with trastuzumab and endocrine therapy. But the caveat to this was the node positivity, in which the affinity trial, which include pertuzumab, which is another HER2 blocker, along with trastuzumab and chemotherapy, with trastuzumab and chemotherapy was compared. So remember, node positive tumors were there and node negative tumors were there in tumor size more than 1 centimeter. The affinity trial created more controversy than anything. And even if when we probably do the panel discussion today, I think the panel will definitely be divided between the two. Something that I really don't also agree. As you can see between the two graphs, node negative cohort, no difference between dual and single HER2 blockade. And in node positive cohort, the curves do start separating, but does it translate finally into a benefit? 87.9, 83.4, something to take with a pinch of salt. So a controversy still, a solution, whether to come out, we don't know. So affinity trial for such individuals. What about extended adjuvant therapy? We all know that post chemotherapy, we need to continue the trastuzumab for a complete period of 1 year. 9 months has been tried, 6 months have been tried, but we all stick to that 1 year. So what after 1 year? So this is a drug which is now considered neratinib, which is now recommended in the hormone positive, HER2 positive disease who are perceived to have high risk of recurrence. So these are the individuals who probably did not get a pathological CR, that is post neoadjuvant therapy, or had node positive disease during surgery. So this was a study, and this was the comparison where neratinib, which is another HER2 blocker, 240 milligrams compared with placebo, and the primary endpoint was disease-free survival at 2 years. So what did we see from this? Again, not much of a difference between 5 years, 90.2 versus 87.7. And remember, all these patients were majority hormone positive. So they did receive the aromatase inhibitor also. So as you can see, in hormone receptor positive only, there was some difference. So whether it is the neratinib which is working, or is it the letrozole or anastrozole that is working, is something that we really need to discuss. No difference in the hormone receptive negative subset. If once again in hormone receptor positive, less than 1 year from the last dose of trastuzumab, again a difference of 5.1. But individuals who did not receive a pathological CR after neoadjuvant, this is where probably the indication of neratinib is really there. So a point to ponder. Coming to the newer adjuvant therapy, and this is where probably I think the role of dual HER2 blockade is where it stays. So remember who have to be considered for pre-operative systemic therapy. That is, who are the ones who need to get chemotherapy before surgery. And I know majority of the surgeons will probably not agree, or maybe will start agreeing. We feel any tumor more than 2 centimeters who are node positive, regardless of the hormone, should receive neoadjuvant chemotherapy with the addition of dual HER2, trastuzumab and pertuzumab. And probably the living example for this are these 2 studies that we've grown up listening to. That is the Neosphere study, and the other being the Trifema study. Different combinations were tried in which dual HER2 along with chemotherapy in the Neosphere, anthracycline in the Trifema, and the main aim of this was to get a pathological CR. So what is a pathological CR? You give the individual a chemotherapy for say 4 cycles or maybe 3 cycles, and subject the patient to surgery. If the histopathological specimen shows a T0 and an N0, that is no disease in the tumor or the node, that is what is called pathological CR. Probably a new surrogate marker for a survival benefit over a time period, but that only time will say. But these 2 studies showed that pathological CR was something which is important. And another thing that this study said, question was the use of anthracycline. So this was further said because both the HER2 blockade caused cardiotoxicity, though it was a type 2 cardiotoxicity which is reversible, but a combination with anthracycline, which causes type 1 cardiotoxicity, irreversible. So could we eliminate this? So this was by the TRAIN study, in which the individuals first received 3 cycles of dual HER2 blockade with chemotherapy in the first block, and the other had FEC, which contained an anthracycline group with a dual HER2 blockade, followed by 6 cycles of common regime, followed by surgery. The primary endpoint was again pathological CR, and the secondary endpoint was safety and RFS. So as you could see, both in the anthracycline arm, whereas and the TCHP arm, the pathological CR was identical, whether clinical T, clinical N, hormone positive or negative, age, the outcomes were similar, which basically told us there was no statistical difference between EFS, and that safely anthracycline can be avoided in such individuals. So what do we do post neoadjuvant therapy? Yes, the patient post neoadjuvant therapy goes to the surgeon, and we wait for the histopathological specimen to see what is there and what is left. So in case the patient has achieved a pathological CR, we continue the combination which we were giving, either a single HER2 if the patient received a trastuzumab, or dual HER2 if the patient in pertuzumab. So we don't change the winning combination. However, if the individual has residual tumor or residual disease in the node, we hike over to the adotrastuzumab emtansine, which we call TDM1, which is a antibody drug conjugate. And this is what the CATHERINE trial told us, that in case the individuals had invasive disease, TDM1 was introduced vis-a-vis the trastuzumab, which was given, and the primary endpoint was a disease-free survival. And when you see these graphs and when you see the light between them, you feel happy. You know that the drug on top really works, and that is what TDM1 did. whether it may be distant recurrence, loco-regional recurrence, contralateral breast, or death without prior events, it was better in the TDM arm. So is it a landmark trial? I would say so, especially in individuals who had residual disease post neoadjuvant therapy. And this was seen across all subsets, especially irrespective of the hormone receptor status, whatever was the pre-op HER2 directed therapy, or the pathological nodal status which was seen. So what is the proposed strategy for managing patients with stage 1 to 3 HER2 early breast cancer? And probably this is my master card or the master slide, if I can say, and so I've kept it here. So in the patient, if he has clinically T1A or B disease less than 1 centimeter without a node, ideally the patient should go for surgery. However, high-risk patients is a place where probably neoadjuvant, and when I mean high-risk, age less than 35, grade 3, hormone receptor negative, or multifocal disease, this is the place where even the neoadjuvant therapy works. Clinically, if T1C disease, that is, if the size of the tumor is more than 1 centimeter but less than 2, this is a gray area. You assess again the risk of the patient. If the patient has high-risk features, the patient should get neoadjuvant chemotherapy along with HER2 blockade, ideally dual HER2, and taken up for surgery thereafter. But if the patient has clinically T2 or more than N1, it is a no-brainer. The patient should receive a neoadjuvant chemotherapy. If there is a residual invasive disease, post-surgery TDM1 for 14 cycles, followed by neratinib, which probably we are still learning how to probably use, or probably will we use is another question. But if the patient has a pathological CR, then continue your pertuzumab and for another and trastuzumab for another 14 cycle. Whether the use of neratinib is there is something which we need to understand further. So these are the NCCN guidelines which are there, and as you can see, the TCH protocol or the TCHP, which consists of docetaxel, carboplatin, trastuzumab, or with pertuzumab, is the ideal treatment. There are treatments which are usually done in certain circumstances, but probably we prefer the preferred regimes. So that is what it is. And we know that chemotherapy has toxicity, and so do have trastuzumab and pertuzumab. So what are these toxicities that are there? Cardiac toxicity, trastuzumab, infusion reaction, and diarrhea, many often. But over a time period, we've learned how to manage all these toxicity. TDM1, a smooth drug, but however, thrombocytopenia and deranged liver function is seen. Individuals have also reported neuropathy or hepatic damage. Neratinib is a drug like any other TKI. It has diarrhea, rash, liver toxicity. I have not used this drug, and probably not many in India, but once the drug comes, it will be a challenge for us to fit it at some place or the other. So what are the future directions which are going on? A number of studies are going on, all in neoadjuvant therapy. IM PASSION is where the role of immunotherapy along with chemotherapy is there, something to look forward to, especially if they have a PD-L1 positive. The APNEO is another trial, a combination of immunotherapy plus chemotherapy. Pulton and Nafier is another, where probably a combination of CDK4/6 inhibitor like palbociclib and letrozole, along with Herceptin and Gorcelin is given, especially in triple positive breast cancer. So something to look forward to. And as they say, the days of the multiplex has already gone, but as soon as we say the end, suddenly the movie theater plays the next trailer of the movie which needs to be put. And that is what I am also doing. And the people sit down to see what is next. So what is next is destiny. And probably it's not that a newer topic now because it's been discussed. But the new kid on the block is the trastuzumab deruxtecan, something next to the Catherine trial where individual has a residual disease. So TDM versus trastuzumab deruxtecan, and we've seen the advantage of DFS which is there, though the data is still completely not mature, but something to look forward to. The COMPASS HER2 RD trial, where adjuvant TDM1 with tucatinib Another TKI, which is again the HER2 versus TDM alone for high-risk individual, where TDM1 was with tucatinib is given. So another study to look forward to, and again, the data for this is not yet matured. So just to summarize on my last slide before I switch off is HER2 positive breast cancer, the availability of HER2 targeted agent has evolved rapidly and the overall outcomes in this patient has improved. We know the HER2 positive breast cancer is an aggressive cancer associated with not just systemic, but as brain metastasis. For patients with small, less than 3 centimeter node negative HER2 positive early breast cancer, paclitaxel with trastuzumab based therapy through the APT trial is the standard of care. Neoadjuvant chemotherapy plus trastuzumab and pertuzumab for patients with HER2 positive tumors more than 2 centimeter with node positive is here to stay, and we recommend that this should be the treatment for these patients. For adjuvant therapy, there are 3 trials which are written. I would just believe in the second, that is the Catherine trial, where the TDM1, especially in individuals with residual invasive disease after neoadjuvant taxane and trastuzumab basic treatment, I think this should be the treatment of choice. Affinity and XTNet. Affinity, I really don't believe too much in, and XTNet is something that I'm waiting for. So with that, I would just like to say thank you to the organizers, and I will hand it over to them. Thank you very much for your patient hearing.
Thank you, Dr. Rahul, sir. Thank you very much for that wonderful presentation. Moving ahead, I would like to invite our chairpersons for the case-based panel discussion, Dr. Somashekhar sir and Dr. Poonam Patil ma'am. Very good evening.
Good evening, both of you, and good evening, all my colleagues. Thank you very much. Actually, that was a fantastic talk from Rahul. I really thoroughly enjoyed. You beautifully summarized crisply, everything, neoadjuvant, adjuvant, emerging technology. Beautiful slides. It's a teaching slides. I thoroughly enjoyed. Beautiful.
Thank you very much, sir. Thank you.
Thank you. So I think we have now case-based panel discussion. I always love case-based panel discussion than a open blanket sort of symposium. And we have my very close colleague, Dr. Amit Rothan, who is a senior medical oncologist at Manipal Comprehensive Cancer Center, Manipal Hospital, Bangalore. And on behalf of Poonam Patil, my colleague, co-chair, I request Amit to please take over and call his panel members and start his case-based panel discussion.
Thank you, Dr. Somashekhar. So I thank Dr. Reddy's for inviting me, giving me this opportunity. I'd like to invite my panelists for this discussion. So we have Dr. Vishwanath, we have Dr. Poonam Maurya, Dr. Neeti, Dr. Vivek, and Dr. Vinayak. So I think all the panelists are there. So we've had an excellent presentation from Dr. Rahul about the data. What we'll do quickly is use this data and see how we manage patients in clinics and what all do we follow. So that's the problem, you always have guidelines and then there is amendments which we do for our patients. So let's start off with this, a case-based discussion. Let's start with just the first part which Dr. Rahul covered was the early stage, very early low-risk patients. I've taken up patients from our own clinics. This is a 48-year-old female, carcinoma right breast. She had a T1N0M0 stage 1, got operated first and then IDC grade 3, ER negative, PR negative, HER2 3+ with a Ki67 of 30%. So Dr. Vishwanath, how do you think about in this group of patients, this very early low risk patients, T1N0M0?
So this patient is, like you said, is very early stage HER2 positive breast cancer and node negative. It's a T1C tumor. So I would probably go with this APT trial. Tulani's study has shown that the 6-year DFS is wonderful, 90 to 94% of DFS, invasive disease-free survival. So I would go with the paclitaxel with trastuzumab weekly times 12 followed by adjuvant trastuzumab. And since the patient is ER/PR negative, I would go for a 1-year trastuzumab.
Right. Okay. So you made a comment on that. So if it was ER/PR positive?
Again, the Persephone 6 months versus 1 year, this has to be discussed with the patient.
Right, right. I agree with you. The data is always the 1 year trastuzumab because of the APT data sets. But this is our temptation, this is the place where we want to try to give 6 months if possible. But of course, the data sets are maximum towards 1 year. Dr. Neeti, do you follow this? What is the cutoff you use? Are you comfortable with 3 centimeters? 2 was the cutoff they had used in the APT trial. Oh, okay. I don't think I'm getting Neeti. Dr. Vivek, could I put this
yourself, Dr. Neeti?
Amit, the question was, if it is 3 centimeter, would I consider upfront surgery or NACP? Is that the question?
No, I was thinking about this APT trial data sets. Do you, if it came to you post surgery with 3 centimeters, so it's a T2 N0 M0, are you comfortable with APT, or would you say no, I will change the chemo?
No, I would prefer to give just 2 drugs, Pacli and trastuzumab. But sometimes a high-grade tumor in a young woman, maybe I would consider probably a dual anti-HER2.
Right. So this trial did have up till 3 centimeters, but the numbers were very small. Most of the numbers were till the 2 centimeters. There were very few of that 3 centimeters also. And that becomes a hesitation in the clinic. But I think we are slowly getting comfortable. Maybe Pacli alone and trastuzumab for a year should be enough till 3 centimeters. Dr. Vivek, what about neoadjuvant chemotherapy in this setting? If the patient comes in to you first, do you consider neoadjuvant for this group, or you are comfortable sending it back to your surgeons?
Oh, I think if this patient is like, a T1 lesion and node negative, and if she's if the surgeon is comfortable to do BCS, then I would ask him to go for surgery upfront. And if he thinks it is not possible for a BCS, then I would consider for neoadjuvant. But
Right.
I think this case would mostly be suitable for upfront surgery.
Right. So I think all of us kind of have concurred on this, and this is how the whole thought has gone on. Early stage, reduce the chemo. This is probably the only de-escalation we have. We always talk of de-escalation, but there's no other de-escalation in breast cancer in HER2 positive space. This is the only de-escalation where you're talking of reduction of the chemotherapy part, and maybe reduction of trastuzumab if you extrapolate some data sets, but of course that's not what APT did. So let's move on to the second part of those, the patients who are not that low risk. So here's a 54-year-old female, carcinoma left breast. She had CT3N1M0, IDC grade 3, ERPR positive, HER2 3+, Ki67 50%. Dr. Poonam, to you, what are your thoughts on this, Dr. Poonam Maurya? How are you thinking about in this group of patients?
Yeah, hello. She's a T3N1M0, so definitely it's a locally advanced breast cancer, and she's HER2 positive. So I would like to start on a neoadjuvant chemotherapy first, and then assess for the surgery later. So neoadjuvant therapy, including anti-HER2 agent as well. So most commonly we use trastuzumab. And we can use TCH. Many combinations are available, or if affordable, then TCHP also can be used.
Right. So given a choice, these are patients, do you push them for TCHP saying pertuzumab has that benefit, or are you comfortable with TCH in clinical practice?
Actually, in clinical practice, most of the times pertuzumab affordability patients usually turn up saying no only. So we end up using TCH. Pertuzumab is only on these discussions like we are having today for early breast cancer, give TCH and all. This is only for discussion, but practice may it's only TCH.
Right, I agree. Many patients cannot afford TCH, but there is always a group of patients. I know Dr. Poonam is there as a chair, and I've seen she has one of the biggest experiences with TCHP in practice. So we have actually assimilated data, and she has a very good experience with TCHP.
Oh, okay.
So I think so we all agree with neoadjuvant chemo, even if this was of course locally advanced, but even in non-locally advanced, we agree with neoadjuvant chemo. And I think a very important change that has happened was we are now having a lot of talk about downstaging of axilla. And that's something which has changed in practice. Earlier we used to talk of downstaging of breast and breast conservation, and that's something all of us were very comfortable with. But downstaging of axilla has become very important, and that's something which drives more and more operable breast cancers going in for neoadjuvant therapy in these situations. And I think from medical point of view, for us, another important part is allowing time for genetic testing. Though in the HER2 population, it may not be that important, but allowing time, especially in those triple negatives, for genetic testing is important. So we've seen that clearly we prefer neoadjuvant chemo. Dr. Rahul told us clearly better survival. Dr. Vinayak, can I come to you? So we discussed about the regimes. We've seen the TRAIN2 data. Are you in practice still continuing anthracyclines, or are you more on the TCH kind without the anthracyclines? What are your thoughts on this?
No, so in my practice, I don't use anthracyclines much. I would prefer to use TCH along with pertuzumab whenever it's feasible.
Right. So, okay. Dr. Vishwanath, do you have some groups of patients where you want to give an anthracycline, or do you also believe that TCH is good enough, or is a good regime for these group of patients?
Yeah, first of all, I would like to push for TCHP considering the PCR and the EFS and the DFS. But if not, I would, if the patient is definitely N2 or more, I always give anthracyclines sequentially. And but TCH if it is probably N1. Though the BCARG 006 has shown us that, but still, it's always a temptation with N2. I always give anthracyclines, and the TRAIN2 data definitely is very impressive. So going forward, maybe I might change my practice.
Right. So Dr. Vishwanath mentioned this, that he would like to push for TCHP, and we have seen this data. I think if patients can afford it, I also would say it's better to give TCHP than TCH. Definitely the PCR rates are higher. And we actually did an analysis in our center, and we saw our TCHP PAT CRs with 80%, which is amazing. And we had somewhere around 60% with TCH. Of course, now we are looking at all the subgroups of looking at ER positive and negatives, but we clearly have seen from the Trifena data that TCHP is better. And one more reason for pushing for this is if you do TCHP neoadjuvant, you kind of can remove the affinity debate from your patients. Otherwise that affinity debate always comes up. Is pertuzumab good as an adjuvant or not? But if you did TCHP and you got PAT CR, then you can actually remove the pertuzumab debate, and you didn't get PAT CR anyway, you're going to again change directions. So I think that's one good reason to look for TCHP upfront. We can remove the affinity thoughts from our discussion. So the TRAIN2, yes, Dr. Rahul showed us, and this is the data. Though I kind of am a little uncomfortable with the regime. I don't think our patients need that 9 cycles of neoadjuvant, which they did in this regime. A very, very odd protocol, not the ones which we use in clinical practice. For us, 6 cycles is good enough, is what we follow. And what I think about this is, even if you did 9 cycles, you still got 67% PAT CR. It's not that by doing more, you're really achieving a lot more PAT CRs. So there are a lot of things about TRAIN2, but yes, it clearly is telling us anthra may not be that useful, and we can get away without anthra. Dr. Neeti, do you use anthra or no anthra? This thing is always a thing which differs from center to center, and everyone's experience is different.
Actually, I think all of us have used anthracycline so much that we are in love with it. So as Vishwanath said, I'll try to focus on giving TCHP wherever feasible. But if it is not feasible, then I'll probably give 4AC followed by TH. I mean, this is what I'll try to use in practice.
Right. Okay. So that's the way I think everyone looks at. So there was one talk where they were talking about, probably if we believe the TRAIN2 and we believe removing the anthra, the only group of patients you'd still give anthra was for patients who have tumor heterogeneity. So we recently had one of the patients who actually had a breast mass where one was HER2 positive and the other mass in the same breast was HER2 negative. And that's one of the reasons for not using a TCHP like regime, and we prefer the anthra-based regime. But otherwise, anything is fine, actually, depending on our convenience and center's preference. So this is our patient. And as Dr. Poonam said, many patients refuse pertuzumab. We offer it to everyone, but they refuse. And this lady refused for pertuzumab, saying that, no, the cost was too much, and let's just give TCH and see what happens. So this is what we did. We did TCH for 6 cycles. She went on to surgery followed by reconstruction. And post-op, we saw residual disease and we had RCB1. Dr. Vivek, your thoughts on this are you looking at RCB scoring at present in your pathology specimens, or are you just going by the residual disease present and absent? Some centers do it, some centers don't do it, the RCB scoring.
Oh, sorry. Yeah, our pathologists do give the scoring. Yeah, we do the scoring.
Right. So my thought is, this is the group of patient who's got residual disease with the many. She had RCB1. What do you think, this group of patients, how do you think about managing them further?
Yeah, so now we can definitely consider adjuvant TDM1 in this situation if they can afford, which Catherine has definitely shown very good outcomes with, in this set of population, although the toxicities were quite significant. If they're affordable, definitely I would consider changing to TDM1. Otherwise, I would continue with trastuzumab maintenance. Sorry, trastuzumab maintenance in adjuvant situation.
Yeah. Right. So I think whenever we have residual disease, we are clearly talking of TDM1 to most of our patients. Again, the same situation comes: who would take it and who would not take it. Dr. Poonam Maurya, your thoughts on this? Do you think, even if the residual disease is very minimal, would you offer TDM1, or you would offer it to your patients who are high residual disease? What are your thoughts on that?
Yeah, now with this data coming up from this study, we do offer, we should offer, I think, the TDM1. And we have now the biosimilar available at a less cost. So I think number of people taking up TDM1 will also be high. So we should offer them definitely. Given this wide separation of curves, it is so nice to see such separation of curves. So it is more, it is nice data. Otherwise, otherwise we'll have to go back to our old trastuzumab.
Right. So I think everyone agrees on this thought that better to add TDM1, change it to TDM1 for all these group of patients. My only concerns with the trial is always they didn't do an RCB scoring in the trial, so they did not have a RCB score, and that's been a criticism always which we hear in this Catherine data sets. So we had the old data when the RCB scoring calculator was made, that if RCB1 is, the survivals are as good as RCB0. So if it's RCB2, then the survivals are poorer. So I always have that reluctance, sometimes my thought is, are we over treating RCB1? That's a very, very minimal residual disease. Are we over treating it? But that's, the data did show that even the minimal disease, you did have benefit. And so this is something we always discuss with our patients, and then we take a call of how to go about it. But for a high burden residual disease, absolutely sure, no doubt about it, we offer TDM1. Any experience with TDM1 in this setting, Dr. Vinayak? Have you giving it, and any experience with this? I wanted to know if people are completing it the whole duration, or there are dropouts happening as per what happened in the clinical trial.
So not much experience with giving TDM1 in the adjuvant setting. Only 3 patients on TDM1, yet to complete 1 year. So that's what. Yeah.
Right, 3 patients is a good experience. There's no doubt about that. 3 is good for an adjuvant setting TDM1. So I think so we discuss this with our patients always. But in RCB1, as I said, we had a long chat and we always talk yes, no. But this patient eventually opted for TDM1, which I was very surprising for me, because she refused pertuzumab, but then she opted for TDM1. She finished her course. Now she's almost, I think, a year down the line after finishing her course. There was really no issues with it. She tolerated it very well with no problems, and she was on hormonal therapy. So Dr. Vishwanath, your thoughts on next steps, ERPR positive? Let's talk of maybe this patient had a high residual disease. She's ERPR positive.
Yeah. So so we are coming to neratinib, but unfortunately the neratinib data was more with trastuzumab. I don't think it was with TDM1 adjuvant.
Absolutely, you're correct.
So, and the other thing is, even with dual HER2, for example, trastuzumab plus pertuzumab in the adjuvant setting, there was not much benefit with neratinib. Yes, this patient was ERPR positive, no PAT CR. If this patient had received a single agent trastuzumab in the adjuvant setting, maybe 1 year of neratinib, again, cost constraints, these have to be discussed.
Right. Someone asked me once in a meet that, would you extrapolate saying that you don't have neratinib, but you can still give some benefit of a TKI, and would you want to give your patient lapatinib for 1 year, saying that you don't have anything else? What do you think? This was asked to me actually. So I kind of think there is some thought on it. It's not wrong. There's no data. So what do you think?
Well, I wouldn't give. I would keep it for later.
So anyway, I stuck to that answer. I won't give. but Neeti, would you think of it?
No, Amit. Actually, that's what exactly as Vishwa said. The data for neratinib was collected between 2009 and 2011 and published in 2017. And that time, I think there were no talks about EDM1 or pertuzumab. So whatever talks we have right now on HER2 positive high risk patient and hormone receptor positive for neratinib adjuvant, I think probably we need to revise all that data and figure out that in the current scenario, what is the utility and how to position it.
Right, I agree fully. The problem is the trials change so fast that the inclusion criteria are already gone, and we now there's that tucatinib trial, and by the time we get neratinib, I'm sure the tucatinib data would have come up, and then it's all gone. Then we are thinking of tucatinib in the adjuvant setting. So it's amazing how fast this is changing. So anyway, that's the extended data, but I also agree with this. I don't think this is going to be very relevant for our practice. Right. So one thought we always talk about our patients and our circumstances in India, and we discussed about the duration of adjuvant therapy, various clinical trials. We always put this chart and discuss pros and cons. So Dr. Vinayak, your thoughts? Would you shorten duration of treatment for your patients in any segment, and which segments would you do it if you would think of it?
So no, sir, I wouldn't want to shorten the adjuvant trastuzumab. I would prefer to complete 1 year of trastuzumab.
Right. So
as we discussed earlier, if there were really cost issues or if they are unable to take it, then probably I would consider giving 9 weeks of trastuzumab. But prefer to complete 1 year.
Right. What about you, Dr. Vivek? This thought of Persephone study having 6 months, and the recent last year's paper from Tata, which actually analyzed it and looked at everything and then said, no, shorter duration is equally good. Most of it is all statistics and the analysis is more statistical. What do you think about that?
Yeah, so I still give 1 year of trastuzumab, but there is data to say that even 6 months is okay in one of the trials which had nearly 4,000 plus patients, I think. Although it is like, one big data was against and one is in favor. The thing is, the reasoning or they conclude saying that within the first 6 months, the benefit of trastuzumab would have been received by the patient. That's a thought process. So again, I think the practice is to continue for 1 year. But in certain, certain patients like early breast cancer with low risk features, probably we can consider a shorter duration is what I think many times.
Right. Correct. So for our situation, sometimes we don't know for sure, but it's still going to be 1 year as per what everyone recommends. But if you read that Dr. Mangulia's paper from Tata, they've done an extensive analysis, and if you read it, they kind of are emphasizing 6 months should be good enough in most situations, and they looked at all the trials, did a meta-analysis, a very, very interesting paper. Dr. Poonam, would you do it for any patient 6 months, or are you fully convinced about only 1 year?
No, even though the data, there might be some data for 6 months convincing, as you told, from Tata and all, but we know that the cancer overall is a heterogeneous disease, and which HER2 patients will be really good and when they will progress, nobody can tell, even if it's early with all the good risk factors. So I think first chance is the best chance, and that's why I think completing 1 year is, I think no doubt it is better rather than giving 6 months and then later within 6 months the disease coming back and then having nothing and as an option.
Right. I think well said. I think that's the best thing, that the first chance is the best chance, a well said statement. And possibly why should we take a chance? If our patients can take it, we should not shorten the duration ourselves. If they can't afford it and it's a different situation, then it's different. But I think that's perfectly right. So we will stick to 1 year of trastuzumab as per most of the data sets. Right, I think with this, we would conclude our discussion. This is what Dr. Rahul also showed his last slide, and I think that's the most important factor of how to choose and how to go about it. But a lot of interesting stuff happening, and I think all of us are very excitedly waiting for all the new things happening. Right, so with this, I thank everyone. I thank all the panelists for that discussion, and I hand it back to Dr. Reddy's, the team there. Thank you very much.
Thank you.
If there are any questions, anyone they can take it up.
Thank you, Dr. Rohit sir, for the wonderful panel discussion. Sir, I just have one question from my side, that with increasing surveillance in the Western countries, especially North America, the rate of metastatic breast cancer at presentation has decreased to 10%. That might be because of increased patient awareness and other screening technologies. What might be the ratio in India, if we can put a figure on that? Is it possible?
I think it varies from various places where you look at, where the centers and the type of patients presenting. I think most regional centers would see a much higher burden of metastatic disease and locally advanced disease. Most of the others, urban centers, would see a little more of the early breast cancer center data sets. So I think we see about we see 75% of our work is early breast cancer and only 25% is metastatic disease at presentation.
All right. Sir, you're on mute, Dr. Sood.
Dr. Amit, would we be using more of TDM1 for Catherine trial now that the biosimilar is here for residual disease?
very difficult question to answer.
It's cheaper than pertuzumab.
I think what always happens with biosimilars is, especially for monoclonal antibodies, it takes a little time to get your hands on it and seeing whether your patients are responding the same way. And that's going to be the difficulty when you're doing it in an adjuvant setting. So it's going to be a little tricky. I personally would, if I would want to try that, would start with the metastatic setting and see whether the drug works for my patients, and then probably only then I would extrapolate. I would be very hesitant to directly extrapolate this, but that's my personal thought.
Right. Thank you.
So, thank you, everybody. Thank you, Dr. Rahul sir, for the talk. Thank you to the chairpersons, Dr. Somashekar sir, Dr. Pranav. Thank you, Dr. Amit sir. Thank you to all the panel members. Thank you. Have a nice day.
Thank you.
Thank you.
Thank you, sir. Thank you, everyone.
Good night.
Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Thank you,
Thank you
all.
all. Dr.
Thank you.
Bye.
Thank you. Bye.